Hi, everyone. My name is Pavlos Msaouel, and I am an oncologist at the University of Texas MD Anderson Cancer Center in Houston. I specialize in treating patients with kidney cancer, lead a research lab focused on developing new therapies for kidney cancer, and design and oversee clinical trials to evaluate these treatments in patients. I have a particular interest in a rare but very aggressive kidney cancer named Renal Medullary Carcinoma, abbreviated as RMC. My laboratory identified the serum biomarker currently used to monitor cancer burden in many patients with RMC, and we also established many of the treatments currently used for RMC. I see in clinic anywhere between 3 to 8 patients with RMC per week as follow-ups and about 1 to 2 new patients with RMC per month. Our team also helps guide the management of most patients diagnosed with RMC around the world. And today, I will answer a few key questions on RMC, starting with, what is RMC? Well, RMC is also known as SMARCB1 deficient renal medullary carcinoma. It is one of the most aggressive kidney cancers. Anyone who has RMC should immediately consult with an expert on this disease. I personally am available 24/7 to advise and share our latest data on RMC with oncologists from all over the world. But what is it that makes RMC so different from kidney cancers that it requires such specialized care? The answer is that just about any therapies used for other kidney cancers, such as clear cell renal cell carcinoma, do not work at all against RMC. In fact, standard immunotherapies used for kidney cancer may actually feed RMC cells and make things worse. At the same time, many of the therapies that do work against RMC do not work against other kidney cancers. This is why it is so important to know what type of kidney cancer you have. Another big difference is that while surgery is often used first in most kidney cancers that appear confined to the kidney, most patients with RMC should not receive surgery first, as this can increase the risk of the cancer spreading faster. Instead, we typically start first with chemotherapy, and if there is good response, then we safely can do surgery. The most common first sign of RMC is blood in the urine, called hematuria, and patients may also feel pain in their flank around the kidney area, or less commonly feel a mass in their abdomen, in their belly, usually on the right side. And RMC mainly afflicts young adults and adolescents of African descent with sickle cell trait, sickle cell disease, or other blood disorders that can cause red blood cells to change into a sickle shape. Men are twice as likely to be affected by RMC than women, and about 3/4 of RMC cases start from the right kidney. RMC is the third most common kidney cancer among children and young adults, and half of the patients diagnosed with RMC will be 21 years old or younger, with some being as young as 9 years old. Less commonly, patients can be 40 years old or older. About 1 in 14 African Americans carry the sickle cell trait, and between 1 in every 20,000 to 1 in every 39,000 of individuals with sickle cell trait will develop RMC conservatively. Sickle cell trait is found in approximately 300 million individuals in the world. And we also now have evidence that high-intensity exercise may be associated with RMC in individuals with sickle cell trait or other sickle hemoglobinopathies. Exercise offers health benefits for everyone, including those with RMC, sickle cell trait, sickle cell disease, or other blood disorders. Moderate exercise may actually lower the risk of RMC compared to a sedentary lifestyle, while prolonged high-intensity exercise could harm the kidneys and increase the risk of RMC in individuals with sickle cell trait or other sickle hemoglobinopathies. Regular, moderate exercise is beneficial, but overexertion may be harmful. Thanks to the collaboration with our patient advocates, RMC research has accelerated dramatically in recent years, resulting in many new treatment options. We now have more than one established therapies for patients whose RMC has become resistant to our initial chemotherapy. We achieved this by developing and completing the three first clinical trials designed specifically for RMC. And when it was first described in 1995, the average survival of a patient with RMC was only 4 months, and this had only improved to 13 months by 2017. This meant that about half of our patients with RMC would not survive beyond a year from diagnosis. We openly set specific milestones to double the average survival to 2 years before the end of 2025 and to 5 years by 2030. Our latest data suggests that we're pretty close to achieving our goal of getting the average survival to 2 years, and that we are now able to cure up to 10% of patients with RMC. To get now the average survival to 5 years, we are furiously conducting research to understand why RMC happens, how to prevent it, and what are its weaknesses that we can use to make new therapies. I am very excited to share that we just opened the 4th clinical trial testing a new treatment called ubamatamab for patients with RMC. Ubamatamab is an antibody designed to redirect the immune system's T cells to attack RMC, even when other immune therapies fail. Stay tuned for upcoming news on a 5th clinical trial for RMC, which we hope to open by late 2025 or early 2026. It is through such research and advocacy efforts that we will reach our ultimate goal of eradicating RMC for all patients. I strongly believe that this is feasible, and thank you very much for the opportunity to talk today about RMC.